life expectancy. Sorry. And just to show you that back a person who was born in 1850, about 150 years ago, had 50% of these people died before the age of 50 at that time. And now a person that will be born in 10, 12, 13 years from now, in very few years from now, 50% of the persons that will be born in 2031 will live almost 100 years. So, well, this is an estimation, of course, but we see that every day in our everyday life, that there is a tremendous increase all over the world of the life expectancy and of the probability to live longer, which is a good thing, is what we want for us, for our families, for our parents or children or whatever. And of course, as I said also this morning, the question is how the medicine and the society, of course, but for us it's mainly the medical questions, how medicine and the society will adapt to this reality, which is a good reality. And in this reality, we know that with the as the age, with the progression of the age, there are more possibilities of loss of function, of frailty, of age-related diseases, with, of course, consequences such as repeated hospitalizations, such as loss of autonomy and death, of course. And if we just see some data a few years ago, the people that go, this is from United States, this data, but I think it's the same thing in all over the world. Especially people over 75, if we focus in this column, that go to visit a physician for a visit, majority of these people, the problem will have hypertension, as you can see here, 53% almost. And then other problems, very common, it's arthritis, but also diabetes, depression, obesity, chronic COPD, chronic pulmonary disease, but also other frequent cardiovascular problems such as ischemic heart disease and heart failure. This is one thing. So cardiovascular diseases are by far the most frequent diseases in the very old people. And also the other reality is that the majority of the people over 85, you see here in yellow columns, they will have more than 4 chronic diseases at the same time. You see here almost 30%, 4 to 5 chronic diseases, and in addition 25% more, it's more than 6 or more, which is almost 55% of these people over 85 will have 4, 5, 6, and so on diseases. So this is the second thing. So very frequent, the cardiovascular diseases in these ages, very frequent to have several morbidities. And the third thing, which is very important, is that despite all that, this part of the population over 80, over 85, remain very heterogeneous. And you can see here, this is a very nice recent paper from the WHO, John Bird, who is the responsible in the WHO of the aging program, showing, you see here the two extreme values. Unfortunately, it does work. This is the 90% of the total population. In these ages over 80, there is a huge heterogeneity. These are people with very good functioning and people with very low functional status. So we cannot put everybody in the same place. We cannot have the same strategy. So we have to identify which are the persons at these ages that have significant loss of function, significant frailty, and which are the patients and the subjects that are, our strategy, therapeutics and diagnostic strategy will be completely different. So these with high, older people with high and stable capacities, on the left part as you see the slide, we will have an attitude which is mainly the same as in younger people. We try to prevent chronic conditions, to treat them. And as we go to the groups with low function, with high frailty, with loss of autonomy, we will have mainly to manage advanced chronic conditions to ensure a dignified late life and so on, and to try to make their life and their quality of life better, of course. So what I want to point out today is that when we evaluate functional capacities and frailty status, of course, is to assess and to know which are the persons that have a risk to lose more rapidly, completely their autonomy, or to have repeated hospitalizations. But also the B here is to better define the ratio, the balance between the risk and the benefits of therapeutic strategies, especially when these therapeutic strategies are, let's say, more heavy, more aggressive, like surgery, like medical treatment with possible side effects and so on. So this, so far in the past, this was resolved saying, oh, I will do this surgery because he's 75. I will not do this surgery because he's 78. Okay? I will give this treatment because he's less than 80 or not because he's more than 80. But as I showed you, this is completely erroneous because, as I said, in the same age group, you can have different types of functionality and capacity. So if we do this effort for evaluating function and frailty is for this reason, to replace the number of chronological age by the real function and the capacities of an individual. And of course, in order to do that, I will not go directly to the interest, just giving few examples in terms of cardiometabolic diseases, cardiovascular diseases. So some very quick examples for diabetes, cardiac surgery, and hypertension. So just one slide for diabetes. We know that hypoglycemia can be an important problem in people taking, for instance, insulin, to give an example. And you see in this study, a very known person, Professor Pilotto, working a lot in this domain of evaluation of frailty and geriatric assessment. He published 4 years earlier that stratification of elderly diabetic patients using a battery of tests he uses called MPI, whatever. It's not important. It's one very nice and very important way to evaluate frailty. There are some others. So can help to identify those patients at high risk who need better treatment. Why? Because the hypoglycemia in these subjects was associated with the results of the MPI, the multidimensional impairment. Those with high frailty for the same disease, diabetes, and for the same doses of and drugs used, had much more hypoglycemic effects than those who were more robust. So you see, by having evaluated before the treatment the frailty status of these persons, we can be able to better tailor the treatment and to know which are the risks for hypoglycemia. It's an example. Another example has to do with cardiac surgery. This is a very important study. 8 years ago now, they classified people undergoing cardiac surgery according to 2 criteria. One criterion was what they call the thoracic surgeon risk score, which is a complicated score concerning the cardiovascular status of a person, the disease. And the second way to classify these people was according to a very simple test, which is the speed of walking speed, okay? And then they combined both. So you have 4 groups, those with low risk, cardiovascular risk, and normal gait. These are good, let's say, patients with low risk and normal gait speed. This was high risk cardiovascular, but normal gait speed, walk speed. And here it's low cardiovascular risk and slow gait speed, and high cardiovascular risk and slow gait speed. Okay, so you can see here that of course, people, according to the STS risk, the risk of complications, mortality and major morbidity after surgery was increasing, but at the same time, the slow gait speed was also have a very important additive value in that way that those people with low cardiovascular risk with this score, but bad low gait speed, were at least as at risk as those with high STS risk but normal gait speed. And if you combine both, you have at very high speed. So you see something that looks very simple and something like very easy to assess, but we don't assess it most of the time, which is walking speed, may have a very good and very important prognostic value, so we can tailor the treatment, saying, well, these patients maybe the risk-benefit ratio is not good. Okay, of course, it's not just one test that will define what we have to do, but we have to take into account, because things are complex, many parameters. But this simple functional parameter, which is the gait speed, may have a major importance in the prediction of the risk. And a review paper 4 years ago in this same domain, they show that by evaluating the function and the fragility and the frailty in older people, I will not read all, but just take an example. We know TAVI is a very used now method for the aortic replacement especially in very old, because it's a less invasive way and surgery. But even for TAVI, we see that frailty strongly predicted functional decline after TAVI. So, and for many types of interventions in cardiovascular disease, having an evaluation and assessment of the function before surgery is of great help. And I will finish with this. We worked a lot also with several other members of our society, and Mirko Petrovic more especially, and people from the Society of Cardiology and Hypertension, the European, and just to specify our therapeutic strategies in hypertensive subjects according not to the age, but according to their frailty and functional status. And just to give you some conclusions of our common paper with the European Society of Hypertension back in 2016, we proposed that accurate information on functional capacity and cognitive status is important, is necessary. We have to pay attention, of course, to multiple drug administration, and also we have to stratify the frailty status by one of the available rapid methods in order to be practically feasible, okay? So, in that way, now, not only geriatricians, but also the other specialties, for instance, the cardiologists, clearly now they put in their guidelines that in older adults, okay, we have to do the frailty, you see this frailty assessment, and according to the frailty status, we have to have different strategies in order to choose and tailor the therapeutics, and also in the more frail, to see if we can correct at least partially this frailty in order to start a more aggressive treatment. And we know, for instance, interventions like nutrition, like dental interventions sometimes, or correcting some sensorial problems, visual or auditive problems, or feet problems. I give some examples, may be very important in reducing the frailty status. Frailty is not something that it's, we can improve that. We can reverse partially at least the frailty process if we evaluate that and if we take measurements. And while I would like to stop here, and the circulation a year and a half ago in a paper with important statement of the American Heart Association, they say there is a critical need for a multitude of large population-based studies and that include a broad spectrum of older patients that correspond to the patient, the real patients, not only extremely selected, very robust, very fit older patients, but also the more frail, because strategies have to be adapted. Thank you for your attention.
Thank